It's really a pleasure to have a good friend of mine join us, Felix Mahfoud from Hamburg in Germany. Felix is really, I mean, to me, Felix, you're one of the pioneers of renal denervation. When I want to know anything about renal denervation, I go to one of your talks, and I know I'm going to be educated, and I know you're always going to be fair and objective about the technology. There's been a lot of up and down about renal denervation, so it's just great to actually have a state of the art of where we stand right now. So thank you, Felix.
Thank you, Azim. Thanks for the invitation, and it's a great honor and pleasure actually to discuss with you renal denervation and provide an overview of a renal denervation. Azim mentioned that we had a quite tough time when you look at the rather short history of catheter-based renal denervation. At least there were ups and downs in its development. It started with experimental studies, and we have really a sound and solid evidence that indicates that whenever you interfere with the renal sympathetic nervous system in various animal models, you can decrease blood pressure, you can decrease cardiac sympathetic activity, but you can also decrease whole body sympathetic activity. And that triggered then smaller proof of concept studies, which finally moved into SYMPLICITY HTN-1 and HTN-2 trials. So the first in-man trials where a catheter-based approach was used to apply radiofrequency energy to the renal arteries. And HTN-1 was the first registry, HTN-2 the first randomized controlled study. And then SYMPLICITY HTN-3 was published, so the first pivotal trial in renal denervation. You know, everybody expected this trial to be positive. No one ever considered it could be neutral or negative for renal denervation, given the large falls in blood pressure that were observed in HTN-1 and HTN-2. By big surprise, SYMPLICITY HTN-3 was neutral. And this was kind of conflicting, not only because we had the registry data and the first randomized trial, HTN-2, which did not utilize an invasive placebo, but a control group at least. HTN-3 provided evidence that the procedure was applied safely, so the primary safety endpoint was met, whereas the primary efficacy endpoint was not met. And this trial was neutral then in patients with resistant hypertension. A couple of months later, and this was the first really conflicting moment with HTN-3 in mind, and given the previous trials that were published, Michel Azizi from France published a paper in The Lancet where he used renal denervation, radiofrequency renal denervation, in combination with an optimal step care standardized antihypertensive treatment in patients with renal denervation, with resistant hypertension. Sorry, and that was a multi-center open-label randomized controlled trials. They did not use an invasive sham or an invasive placebo, but this trial was positive and has met its primary efficacy endpoint. And then we, kind of came to the point where we had to decide on whether we put renal denervation to rest in peace or whether we try to understand what happened in HTN-3 and why this trial was so different compared to other studies. And we and others in Europe and in the US sit together, and we actually identified confounding factors that may have contributed to the neutral outcome of HTN-3. And as you all know, whenever it comes to medication and intensive medication regimens in patients with hypertension, but also with heart failure, we understand that non-adherence is a huge problem. So patients change their antihypertensive regimen throughout the trial, and then you create so much noise that it is very, very difficult to detect the signal of any device-based therapy. The study population, I already mentioned that we started this technology in severely resistant hypertensive individuals. So this is a technology that was used in patients where everything failed. Optimal medical therapy did not lower blood pressure sufficiently, so these patients were then considered for renal denervation. And of course, this is a kind of very sick, severe cohort of patients with long-standing hypertension where vascular remodeling has happened. And we also understood that patients with so-called isolated systolic hypertension, which is a very high systolic and a low diastolic, patients with huge pulse wave velocity, with huge pulse pressures, were those responding least to renal denervation. And lastly, I'm talking to interventional folks. We also understood that the procedure can be carried out in very different manners, and that we have to standardize the procedure, and that we have to focus and concentrate the ablation on regions where we can hit the nerves sufficiently to decrease sympathetic activity. And then we developed, together with companies, several devices that are now being used in clinical practice. The first trials, HTN-1, HTN-2, and 3, they all used a single electrode catheter, which was very different from what we're using now. This is the SPYRAL system. It's a multi-electrode catheter that comes with 4 electrodes. Whenever you remove the wire, so it's an over-the-wire system, whenever you remove the wire, as shown here, the catheter spirals and creates circumferential ablations, which appears to be very important, that we hit the whole circumference of the renal arteries in a 360 degree manner. And we also understood that it is important to get deeper into the renal arteries because the nerves are getting closer to the lumen, particularly in these smaller segmental arteries as shown here. So post bifurcation, we are more efficacious in targeting the renal sympathetic nerves. And that is what we changed. So we revised not only the technology, but also the technique of renal denervation. This catheter here delivers radiofrequency energy for 60 seconds. It's quite flexible, so you can get access to the branches and treat the vessels that range from 3 to 8 millimeters. We've also other technologies available now. One very promising is ultrasound. Ultrasound, as shown here, allows the true circumferential denervation. I'm showing you that in a second. This is the Paradise system. That's a balloon-based renal denervation system. You can appreciate the ultrasound probe here placed in a low-pressure balloon. During the ablation, cooled fluid is constantly flowing through that balloon which protects the endothelium and then heats the periadventitial space up. So we have both features, cooling and protecting the renal artery from the inside, and the heat that penetrates into the perivascular space to ablate the renal sympathetic nerves that are located there. And I'm just showing that thermal gel video here because it nicely shows how efficaciously we can create these ablations now using this particular device. You can see it in a second when it turns around, how the donut is created. And that is exactly what we're doing. So we're separating 2 to 3 ablations per renal artery in the main renal artery. That's now the coaxial view. Here's the ultrasound probe. We're protecting the endothelium, so that is not turning opaque. It's kept clear. And here the donut is actually the heat that was transferred to the perivascular space. And this is an example of out of our cath lab. You can see that we're getting access to the renal arteries. We are introducing a wire. We're introducing the balloon. We're occluding the vessel. We check that we have truly occluded the renal arteries. And then we emit ultrasound for 7 seconds. We do 2 to 3 emissions per renal artery, and then we're done. And that takes 20 minutes for ablations on both sides. What was different in the new trials, and this is probably what we call now renal denervation RCTs 2.0, so the next generation of clinical evidence that we created. We conducted trials where we where we purposely excluded patients with severe treatment-resistant hypertension, but as we would investigate antihypertensive medication, we thought it is the purest population to investigate indeed is a patient population with low risk, moderate hypertension that are not treated with any antihypertensive therapy. So we completely switched the patient population from severe resistant hypertension to low risk, moderate hypertension. And we included patients who were drug naive or patients that were considered to be safely washed out from their concomitant antihypertensive treatment. We measured adherence using toxicological analysis to make sure that the patients were really washed out, that there was no concomitant antihypertensive medication in that particular patient enrolled in this study. So very, very different from the previous trials, patients not treated with any antihypertensive medication. And probably more importantly, from a clinical perspective, was not the proof of concept in patients not treated with medication. We, of course, said from the very beginning, we also have to confirm that denervation lowers blood pressure in the presence of antihypertensive medication. So we created the SPYRAL HTN-OFF trial, for instance, where we enrolled patients with moderate hypertension that received 1 to 3 commonly prescribed antihypertensive agents. But here, we restricted it to 3, not more, and we used toxicological analysis to make sure that the patients are really adherent to the prescribed regimen to make sure that there is no up and down titration in drugs and that these drugs are not changed throughout the study period. And the results were quite interesting, amazing to see that in SPYRAL off-med, so in patients not treated with antihypertensive medication using that circumferential spiral catheter, there was a significant fall in ambulatory blood pressure. Interestingly, no change in the sham group, and this is very different from HTN-3, where we had a large drop in blood pressure. Next trial, SPYRAL Unmet, again the same catheter as shown here on the right-hand side, the spiral catheter, but here used in patients treated with medication, 1, 2, or 3 drugs, and here the blood pressure fall was larger, 9 millimeters of mercury, for a change in 24-hour systolic blood pressure, and no significant change in sham-treated patients. And lastly, the RADIANCE solo trial, the ultrasound catheter, the balloon-based catheter, which is shown here on the right-hand side. Significant falls in daytime ambulatory blood pressure. That was the primary endpoint here, by 8.5 millimeters of mercury, and also here no significant change in patients with sham treatment. So 3 independent trials, and all of them confirmed the blood pressure lowering efficacy of renal denervation in the presence, but also in the absence of antihypertensive medication. And at ACC this year, which unfortunately, as you all know, took place on a virtual basis, we presented the first pivotal trial. So the off-med pivotal trial, as mentioned before, these were designed as feasibility studies, and now this is the first pivotal study where we had 2 powered efficacy endpoints. Again, this trial was carried out in patients not receiving any antihypertensive medication. We had 2 powered endpoints, 24-hour systolic blood pressure change at 3 months, but also change in systolic office blood pressure at 3 months. And of course, we also looked into safety events at 1 and 3 months. We used an Bayesian adaptive study design with informative prior. We utilized feasibility trial data, the 80 patients that I just presented. And then we calculated the pivotal trial with a maximum of 353 patients that had to be randomized. The first primary analysis was run at 210 patients that were randomized, successfully randomized, and then the DSMB was provided with stopping criteria if they were met, and the stopping criteria was more than 97% probability of superiority on both the primary and the secondary efficacy endpoint. The trial was stopped, and indeed, the DSMB recommended that we halted the study because the stopping criteria were met. We stopped enrollment, and we have now 331 patients that were randomized, that were part of this primary analysis of the first pivotal trial, 166 randomized to renal denervation, 165 in sham controlled, and we have 98% and 99% clinical follow-up at 3 months available. The procedure was very safe, and I think that is of particular interest when it comes to the clinical adoption of this technology, particularly in patients with low to moderate hypertension and risk, cardiovascular risk, it's important to take the safety into consideration. And it looks here that indeed the radiofrequency renal denervation was quite safe. There were no re-interventions on the renal artery performance, any dissections or vascular complications that occurred in these patients. When you think through it, that you take patients off medication, you randomize them in the study, you perform renal denervation in the one group and sham in the other, and you blind patients and physicians. At follow-up, when blood pressure is measured and it exceeded guideline recommended thresholds, we recommended to reinitiate antihypertensive medication. And at 3 months, that is the longest period which was considered by the FDA to be safe with no antihypertensive medication. After 3 months, we reinitiated antihypertensive medication. And if that blood pressure exceeded certain levels before the 3 months follow-up, patients met the safety escape criteria. And it's interesting to see, although everybody was blinded, physician and patients, the number of patients in the sham control group was almost doubled compared to the renal denervation group. Again, those patients meeting safety escape criteria. And this disfavors renal denervation when it comes to the primary endpoint collection, because the sham group received then antihypertensive medication with the blood pressure lowering in that group too. This is another important thing. As mentioned, we have included patients that were purposely washed out or drug naive. And even if you include patients in an invasive trial with an invasive sham, not all patients follow the protocol. And as shown here, already at baseline, 1 out of 10 patients took antihypertensive medications. What was quite interesting to see that this was not changing throughout the study period, but it was probably more interesting to see that the patients were taking all types of antihypertensive medication, even drugs that were not prescribed to them, probably the wife's antihypertensive drugs or drugs that were, at home, available at home. But it's really amazing. Understanding adherence, particularly to antihypertensive medication, is quite difficult, quite challenging, and obviously deserves future investigation. But again, here in this trial, the off-med compliance was the same between renal denervation and sham. So a change in medication compliance did obviously not explain the blood pressure fall. And even throughout the trial, there was no significant change in medication regimen. And what are the results? As said, we have both powered primary efficacy endpoint, which was 24-hour blood pressure and also office. And interesting to see, no significant sham effect even in this trial, and a larger blood pressure fall in patients that were treated with renal denervation. And it ranged somewhere in between 9/5 in office and 5/4 in 24-hour systolic blood pressure. So the trial did meet its primary efficacy endpoint. It was positive and clearly indicates that renal denervation lowers blood pressure more efficaciously than a sham control. What is a distinct feature of renal denervation is the fact that it lowers blood pressure throughout the 24-hour cycle. And this is a huge advantage because, as you all know, with medication, you have peak and trough levels. And according to the plasma concentration of the agent, you can see blood pressure falls after medication intake, but you can also see that blood pressure is increasing again when the medication is no longer acting. And this is different with renal denervation. You can see here the baseline blood pressure on the left-hand side for renal denervation, on the right-hand side for sham. And if you do a renal denervation, you would just lower the 24-hour blood pressure throughout the whole time. So the hour-by-hour blood pressure is significantly altered by renal denervation. And on the right-hand side, here's the sham control, where the curves are superimposed, indicating that there was no effect on blood pressure post-sham treatment. Any subgroups that particularly benefited from renal denervation? We looked into age, we looked into sex, BMI, smoking, diabetes, race, and obviously there was no subgroup that clearly had a higher likelihood of response to renal denervation. This is a moving target, so we're trying to identify responders to renal denervation. I mean, the best would be to identify responders prior to exposure of the technology. That's something we're working on now scientifically. But in this trial, and that represents the largest trial in renal denervation, yet we have not identified a subgroup that particularly benefited from renal denervation. It appears to be across all subgroups. This was the first pivotal trial that was positive. Do we have evidence that compares radiofrequency versus ultrasound? Do we have head-to-head comparisons? And do we have evidence in patients with severe hypertension? And one trial that investigated this was the Radiosound trial out of Leipzig here in Germany, where they compared not only two different modalities, RF, as you have seen before, and ultrasound, but also different techniques. So here they applied radiofrequency denervation to the main only. They applied it to the main and to the branches. Again, this is related to the fact that the nerves are getting closer to the lumen and the segmental arteries and are probably better accessible to RF technology. And they compared these two techniques with ultrasound in the main in patients with severe resistant hypertension. And the results are shown here. So this blue and red is radiofrequency, blue and green is radiofrequency, apologies, and red here is ultrasound. The difference between radiofrequency in the main and ultrasound was significant. So a larger fall in patients that were treated with ultrasound and no significant difference when you compare radiofrequency in the branch and the main renal artery to ultrasound. So I think this trial shows that each and every device comes with its own treatment recommendation, and it also confirms preclinical and clinical evidence that indeed patients should not receive main renal artery treatment with that RF technology. Only if you use that catheter, you have to go into the branches and you have to treat these smaller segmental arteries as well. What else is on the horizon? What are we working clinically, or at least in clinical studies at the moment? What are we investigating? We have ultrasound, we have radiofrequency, and now we're using a chemical renal denervation too. And this is a quite interesting approach. It utilizes alcohol, and as you all know, alcohol is neurotoxic. And this dedicated catheter comes with 4 microneedles, and these microneedles puncture the medium, and then you inject alcohol. Alcohol spreads circumferentially in the perivascular region, and then it affects the renal sympathetic nerves that are located. We typically use 0.6 ml of alcohols, and this is a quite straightforward procedure, and this is real time. Here, the procedure was done here in our cath lab, so we inject a contrast media, we engage the guiding catheter, we expand small guiding tubes, you can see them here, that help to center the device. You deploy the needles, you inject alcohol, you retrieve the needles, you close the guiding tubes, you remove the catheter, and then you check that the artery is patent, and that takes 5 to 10 minutes. So really interesting approach from a procedural perspective. It's probably the most straightforward procedure compared to any other device. It does not require a generator, any other technology, software. It's just the catheter and some pure alcohol, ethanol 100%, that you need to perform chemical renal denervation in that patient. We completed the first in-man trial with this catheter here. Primary endpoint was office blood pressure change. It was first in man, of course, non-randomized, so there is no control group available, but we also used ambulatory blood pressure. We also used toxicological analysis. So this is a state-of-the-art study that used the methodology that was recommended by consensus groups. In that trial, 45 patients were enrolled with severe hypertension, and you can see that we had documented significant falls in office blood pressure, 18/10, and that was confirmed by ambulatory blood pressure, which was reduced by 12/7. So quite promising I guess. And we have now 3 trials. If you want to summarize the evidence that is available, we have now 3 trials, 3 independent, randomized, sham-controlled trials. The SPYRAL-OFF pivotal study, which was the first trial, the first pivotal trial that was completed in this setting of RCTs 2.0 with renal denervation. We have the Unmet trial that was positive, and the RADIANCE solo trial that was positive. But that's not all. By end of this year, probably a bit delayed because of COVID-19, beginning of next year, we will see 4 other pivotal trials to be completed. RADIANCE 2 is the ultrasound catheter in a larger cohort of patients not treated with any concomitant medication. We will get the results of the Unmet pivotal study. So this catheter here, the SPYRAL catheter in patients treated with medication. The ultrasound catheter in patients on 4 medications carried out in Asia is considered a pivotal trial, and the RADIANCE HTN trio trial, patients with resistant hypertension on a triple fixed combination randomized to renal denervation with ultrasound or sham treatment. So 4 trials that will end up, or we will end up by next year with probably 1,600 patients treated in very carefully designed sham-controlled trials. And I, of course, hope that these trials indicate the safety, but also the efficacy of renal denervation. Up to date, I think the recent evidence clearly indicates that renal denervation lowers blood pressure. I think that is an evidence-based and evidence-sound statement. We provided with these trials the proof of principle that renal denervation lowers blood pressure when it's done correctly, and when you affect sympathetic nerve, you have the opportunity and the possibility to decrease blood pressure in patients with hypertension. So we're probably sailing into calmer waters with renal denervation. We're completing our homework, but more scientific work is of course needed before this trial. Before more trials are needed before the evidence is so solid that renal denervation may be used in clinical practice, before clinical adoption is achieved. And this is something that I wanted to discuss with you in the next 10 minutes or so before we come to the discussion. The unmet needs. So what is needed from my perspective before a renal denervation will make it into clinical practice and clinical adoption will happen with this technology. As said, probably the most important thing is that we identify responders. At the moment, we have some vague ideas on where we are moving. In all the trials, the only solid parameter that predicted outcome was baseline systolic blood pressure. The higher it was, the greater was the fall, but this is of course in part related to regression to the mean. So we need measures, we need biomarkers, we need to identify patients that respond to renal denervation with a high likelihood, so that those patients here that had no change in blood pressure are not exposed to the procedure. And it's across all groups, across all studies, it's 1 out of 4 patients, 1 out of 3 patients that is not responding in the so-called definition of response, which is 5 millimeters of mercury for ambulatory blood pressure or 10 for office systolic blood pressure. So, it's important to keep in mind that we need to identify responders, and that is what we are working on. One interesting thing that was published, and I think that is where we need more trials to investigate and more trials on that topic, it's heart rate. I mean, obviously heart rate is influenced by the sympathetic nervous system. And unlike previous trials, the patients in SPYRAL-OFF did not receive any concomitant antihypertensive medication, including heart rate varying drugs or modifying drugs such as beta blockers. And in SPYRAL-OFF, it was interesting to see that patients, as shown on the left-hand side, with a heart rate above 73, had a larger fall in blood pressure compared to patients with heart rates below 73. So high heart rate in the absence of heart rate modifying drugs may be a predictor of response and may help to identify patients that have a higher likelihood of response. Not only that we can probably identify patients with a higher likelihood of response, it was amazing for me to see that we also modified heart rate in the SPYRAL-OFF trial. And this is an evidence that you decrease not only renal sympathetic nervous system activity, but also central and thereby cardiac sympathetic activity. There was a reduction in 24-hour heart rate at 3 months in the renal denervation group by 2.5 beats and no change in the sham group. So the first evidence that we lower not only blood pressure, but also heart rate whenever we interfere with the cardio-renal axis of the sympathetic nervous system. In principle, and this is something of interest for us interventionalists, we could also use renal artery stimulation to identify the density and probably also the activity of afferent sympathetic nerves. So these nerves connect the kidney with the brain, and in principle, we should be able to stimulate those nerves. We should be able to assess an increase in blood pressure and heart rate whenever we increase afferent renal sympathetic traffic. And then we should, in principle, identify spots where the density of these nerves is high, and then ablate these nerves at that particular location, stimulate again, and see whether or not that confers into a lowering of blood pressure. What we did is a first-in-man trial that approached the renal sympathetic nerves with electrical stimulation. And these were 20 patients with hypertension. We used a dedicated catheter that was introduced into the renal arteries. And what we then did is we measured blood pressure during stimulation, and we defined a kind of threshold, which was an increase in mean arterial pressure of 3.5. It was below. These patients were considered non-responders. And as you can see here, 1 out of 3 patients were non-responders. And it was interesting also to appreciate that there were specific locations along the renal arteries where the increase in blood pressure was much higher compared to others. So if you take, for instance, this artery here, we stimulated along the renal artery, there was an increase in blood pressure of 16 to 12 millimeters of mercury. And in that patient here, on the left side, there was no change in blood pressure. And here, that patient had on this particular location a decrease in blood pressure of 34 millimeters of mercury. So, it appears that the location of the sympathetic nerves plays an important role, and that it may be useful to have this available in our hands. But of course, we need further evidence to confirm the feasibility of this approach. Secondly, an unmet need is the question on the sustained efficacy. We know from transplantation, organ transplantation, that the heart, for instance, can reinnervate. We do not have any solid evidence that the kidneys reinnervate post-transplant. But of course, it would be interesting to understand whether there is a functional reinnervation of the renal sympathetic nerves after a catheter-based renal denervation. And this was published and very recently presented at the AHA meeting. Colleagues out of Australia performed catheter-based renal denervation in sheep and followed them for 30 months. So this is the longest time period that was followed. The follow-up was the longest time period ever being published post a catheter-based renal denervation. And there was absolutely, in that model of chronic kidney disease that associates with high blood pressure, there was absolutely no indication that there was functional reinnervation of the renal nerves in that a particular model post-denervation. So we have at least some evidence that there is no significant reinnervation of the renal parenchyma post-renal denervation. And we also get insights clinically from an international effort, the Global SYMPLICITY Registry, where we are enrolling patients out of almost all regions in the world, geographies, 43 countries, 200 sites, and we have 2,800 patients enrolled up to date. It's the largest data set available, and we recently published the long-term follow-up of these patients, and the only clinical measurement of long-term efficacy is, of course, the blood pressure lowering, and as shown here, for both 24-hour systolic, but also for office blood pressure, there is no indication of a secondary rise in blood pressure in this registry, which provides important information for the clinical use of this technology. Any subgroup in this large patient group that particularly benefited, we looked into resistant hypertension. As said, this was the starting point of renal denervation, and even in patients with resistant hypertension, elderly and diabetics, across all the groups, there was a significant fall in blood pressure documented. In diabetics, in patients with isolated systolic hypertension, smaller falls up to 1 year, but then they are picking up, obviously, at 2 and 3 years. CKD, atrial fibrillation. So across all high-risk groups of patients, there was a consistent fall in blood pressure. Real-time feedback, as said, stimulation is probably something we may want to use in the cath lab. We're all doing procedures, and it's quite unusual for us, and I'm not feeling very confident during the procedure because there is no real-time feedback. So we're doing the procedure to the best of our knowledge, and then we start praying when we leave the cath lab that this particular patient had significantly nerves affected, so that there is a blood pressure fall documented later on. But in the cath lab, there is nothing that helps us to document at the moment, to document that we completed our job. So what are we investigating? This is one study where they again stimulated the renal arteries at the beginning. They did the denervation, stimulated again, and you can see here that the blood pressure peak at the beginning was 50, and post-denervation it was 13, and that the higher the decrease was, the higher the delta was acutely, the greater was the future fall in blood pressure in that patient. So that is quite interesting. Unblinding, this is also something interesting where colleagues here out of Australia, again, not only stimulated the renal artery, but they stimulated the aortic-renal ganglia that are located here at the aorta, close to the, or superior to the offtake of the renal arteries, as shown here. So this is the renal artery, the kidney parenchyma, the main renal artery here. This is the aorta, and just above the aorta, there is that aortic-renal ganglia that carries almost all nerves that then travel to the kidneys. And here's the vein, and what they did is they stimulated the aortic-renal ganglia through the artery and through the vein. And what happens is quite interesting. I'm showing you that here. So before pacing, you can see this is an animal model, obviously. Before pacing, you can see that there is a nice perfusion of the kidneys. During pacing, sympathetic activity increases and vasoconstriction is induced. Nice. And then they did a denervation, stimulated again, and documented that this stimulation induced vasoconstriction was diminished. So this may be a procedure that helps us to confirm that we really completed our job in the cath lab and that the sympathetic nerves are significantly hit to an extent that then likely corresponds in a fall in blood pressure. So this was actually my overview. Probably this is the best summary of it. More to come, stay tuned. It was quite tough to get there, but I think we're almost there. We completed several important trials with some resilience from investigators around the world that helped us doing it. But, you know, I think we can state now that denervation lowers blood pressure. We need some more studies before we have identified the best patient cohort, before clinical adoption will happen. But I think we moved a big step forward. Thank you very much for your attention.
Excellent. Felix, thank you so much. That was great. And I think, you know, there were a lot of questions that came along the way. I think you actually answered a lot of them. But we also, you know, I did a quick poll of the audience just to understand, and I'm going to share the results. So I asked, you know, is renal denervation available in your center? So it just shows that, you know, majority of us still don't have renal denervation available. So 88% said no. Okay. And then we also asked, you know, would you like to start renal denervation in your center? And 91% they said yes. You were very convincing.
That's good.
No. So I did want to ask before I pass it on to Shun. You know, a lot of our audience is from the United States. can you give us, and I don't know if you know this or not, some idea about when you think renal denervation will be approved in the US? And also, what do you think the indication for renal denervation is in the real world? I mean, is it off meds patients, as their first therapy? Is it for resistant hypertension? Where should we in the US be thinking about renal denervation?
So I think first clinical indication is patient with uncontrolled blood pressure. We have, I want to say the problem, but it's a kind of luxury problem. So the inclusion criteria in these trials were so broad that you can argue we should include patients that are not treated with any antihypertensive medication. But you could also argue that particularly patients on 2, 3, 4 drugs that are still uncontrolled are the best target population. I think clinically, and that is how we are approaching it at the moment, patients with uncontrolled or difficult to control hypertension on 2, 3 or more drugs, the so-called severe hypertension or resistant hypertension group is probably an interesting one. High risk, high cardiovascular risk, patients with uncontrolled blood pressure, but also patients, and that is quite frequently observed when you run hypertension clinics, those patients with severe side effects to antihypertensive medication who are not able or not willing to take their drugs lifelong are potential candidates for this technology. So I think it's quite broad. And first, we have to reiterate that the safety is obviously quite reasonable. All the trials indicated that the procedure is safe. So I think we have also good reasons to move to patients at the lower spectrum of cardiovascular risk.
Well, excellent. We work here at Monty in the Bronx. It's a very diverse population. There's also, often issues with adherence to pharmacology. I saw only on one slide, maybe a sub-analysis looking at different groups, and that African American seemed to respond. Do we know anything else about the impact of renal denervation, or the impact of race on the results of renal denervation? Considering that we do know, for example, certain antihypertensives work as well in African Americans, but we have here African Americans, Hispanics. We have a very diverse group in the Bronx.
So we looked into it, but there was no indication that one race had a different response profile than the other one. And I don't think that there is good arguments other than that there may be a concomitant use or concomitant mechanism of action, combination of drugs with denervation. That may be a good argument, I guess. And we know that especially African Americans, they have a low renin hypertension. So that may also be an interesting approach to renal denervation. But at the moment, and unlike HTN-3, where this was more related to the fact that the African American patients in HTN-3 showed the worst adherence to medication, we have seen that they did not respond to renal denervation, which was not confirmed by any other study.
Okay. Shun, I'll let you address the questions from the chat.
Sounds good. Thank you for a very comprehensive overview, Dr. Mahfoud. I have a couple questions of my own. So before this talk, I was actually pretty discouraged about renal denervation because the last data I knew was SYMPLICITY 3. And your talk pretty much flipped it around, that there's a lot of exciting new data coming up. On that note, can you comment on why the SYMPLICITY 3 data was kind of negative or neutral? I know there's more better technology. It seems like location where you ablate seems to affect a lot of the effect. If you could comment on what's changed and what was not the best about the SYMPLICITY.
Sure. So I never expected that I would ever say this, but HTN-3 was a very important trial for the field. It was neutral. That moved us into a big depression, but it also encouraged us to understand what happened in the trial, and to understand the learnings were enormous. We identified confounding factors, as said, the patient population. We looked into the procedure. We looked into medication. We would never ever consider denervation in patients off medications without HTN-3, without the neutral trial in patients with resistant hypertension. So this was an important trial. for our learnings about clinical studies, about sham procedures, invasive sham, the impact of invasive sham. So quite nice study from that perspective. But it also teached us that, you know, we have to question ourselves when we see results that are different. We did it. And, you know, when you do your homework, when you try to minimize confounding, and this is probably something we have to keep in mind also when it comes to other studies, yeah, and minimize confounding. And don't forget that sham is very, very effective in lowering blood pressure. And irrespective of the trial that you keep in mind, take a look in Orbiter, right? Orbiter shows an improvement after PCI, but that is much smaller than what we expected and what we anticipated what PCI would do, right? And then you can challenge the sample size and how they did it. But what happens when you introduce sham to a clinical trial is you subtract every unrelated effect of the procedure. But that is not what the patient is interested in, right? The patient is not interested in that delta of blood pressure fall. The patient is interested in his or her fall in blood pressure overall. May it the pure effect of the procedure, or is that a combination of the device with placebo, Hawthorne, medication whatsoever? At the end, it is important that we lower blood pressure in patients. And again, HTN-3 was a very important trial, and it taught us a lot about appropriate clinical trial design.
Sounds good. On that note, I have another question. I understand that actual drop in the number of the blood pressure is important, obviously, that's one, but far more important is, can you reduce clinical events after? And I briefly heard about one trial in South Africa, AFib occurrence decreased after renal denervation. If you could comment on your future vision of how this technology can actually affect clinical outcome for the patients, and whether the indication will lead in a certain way.
That's a very good question, actually. Lowering blood pressure, such as lowering LDL cholesterol, is accepted by the FDA as an endpoint where no additional outcome data is necessary for approval, right? So if you lower blood pressure with an agent or with a device, it is assumed that you improve outcomes of patients. So there is no need to show in a hard outcome trial that this particular device improves or reduces morbidity and mortality of patients. So I think that is an important aspect. We don't need it yet, but we need probably more data in high-risk individuals, and that is why the registry is so important. We need to understand what happens in patients with diabetes, what happens in patients post-stroke, atrial fibrillation. And to your last question regarding atrial fibrillation, there are 2 trials ongoing, and 2 are published. One in the JAMA out of New York, actually. Jonathan Steinberg published that paper where he used denervation in combination with pulmonary vein isolation, and he found and documented freedom from AF that was significantly higher post-denervation than post-sham treatment after pulmonary vein isolation. So that's an interesting approach. We are looking into heart failure. We are looking into post-myocardial infarction patients now. So we're switching from that resistant or hypertension-oriented focus more on a morbidity focus. I showed you data that indicates that we reduce heart rate in patients post-denervation, and that of course opens the door for investigation of this technology, the pleiotropic effects of this technology.
Sounds good. If I could address some question from the chat regarding the procedure, similar to whether like ablation for pulmonary vein isolation could lead to pulmonary vein stenosis. Is there any risk of renal artery stenosis after ablation?
Of course, whenever you touch the artery, there's a potential risk of inducing stenosis, but up to date, the event rate is very low. Even in the registry, we see renal artery stenosis that are below 0.5%. So no indication that you induce renal artery stenosis. In the trials with limited follow-up of 6 months, of 12 months, there is no indication of stenosis post-treatment, even in the smaller segmental arteries. But here we need more patients to be treated and longer follow-up, of course. But at the moment, no sign of increased risk of renal artery stenosis.
Sounds good. And are there any parameters to define successful procedure immediately after renal denervation on the table? Anything you know, and how long after the procedure do you realize there's a drop in blood pressure?
Yeah. So as said, the stimulation is probably the most promising one. We're working on some resistance stuff comparable to FFR. We're looking into perfusion of the kidneys together with Felix on whether the perfusion of the parenchyma tells you something about the resistance, and that could then translate to the sympathetic nervous system activity. Lots of things are under investigation, but nothing turned out yet to be the only or the one parameter that we should measure, but that's, I think, a matter of timing. So sooner or later we'll identify one. Sounds good.
And what's the durability of ultrasound-based or all the devices? What's the durability of these renal denervation?
So I showed you the preclinical evidence that we have, 30 months preclinical sheep data, and we have 3-year patient follow-up where there is no indication of reinnervation. It could happen in some patients that there is a functional regrow of these nerves and that there is a secondary rise in blood pressure and that we would have to repeat the procedure. But at the moment, we have not the evidence yet to tell that.
I see. And on that note, one of the questions was, after transplant, is there reinnervation?
Yeah, there's some very old data, almost historical data, where they looked into post-mortem in transplant patients. They identified and measured the nerves, but post-mortem, it's of course impossible to state whether the nerves are active or not. In humans, this has never been looked at because all the tracers that would tell you whether a kidney is reinnervated are renally excreted. So it's impossible to say whether the kidneys are reinnervated using any scintigraphy or MR or CT. The nerves are too small to be visualized. And then again, you do not know if they are functioning. So it's one of the, interestingly enough, although we have all the evidence and the clinical experience with renal transplant, we do not know whether the nerves are regrowing over time. I don't think so, but in principle, it could happen, of course. You never know.
Sounds good. Is there any higher efficacy of renal denervation patients with higher renin level?
Very good question. Excellent question, actually. That's one of the analyses we are running now out of SPYRAL off-med. Quite interesting data. We will present that very soon, and that looks quite promising.
I see. Sounds good. And can you discuss the size of the effect, especially compared to other routine antihypertensives?
Yeah, very important point. We discussed it already. So it's sham corrected. So the overall fall is smaller than what you anticipate clinically. That's the first comment. The second one is it's the pure effect of the device, and it's comparable to 1.5 to 2 drugs long-term. So it's not replacing 5 to 7, 8, 9 drugs, but it's replacing 1.5 to 2 drugs long-term. And this is quite major. Don't forget, 10 millimeters of mercury off a systolic blood pressure fall correspond to 30% lower relative risk of stroke, heart failure, and 15% mortality risk reduction. So if you can sustain that through a 24-hour cycle, that should improve outcome as well. And on another note, you have seen it, the variability is quite large. There are also patients with a blood pressure fall of 20, 25, 30. So these are the patients we want to identify, and that is why this identification of responder topic is so hot and so important.
Right. There's also a good question here from Nelson, one of our attendings, about, most patients with resistant hypertension have concomitant renal insufficiency or decreased GFRs. How do you manage this with contrast? I mean, can you minimize the amount of contrast that you need? How much contrast do you need for a procedure like this? And also, Felix, I know you've looked at, maybe you could just share with us the impact of renal denervation on creatinine and clearance.
Yeah. So overall, acutely, there is no change in eGFR. That's probably the most robust parameter that we can assess. If you look into the registry, we published that very recently in the European Heart Journal. The eGFR in patients with preserved eGFR, preserved renal function remains stable, and in patients with severe hypertension and impaired renal function, there's a slight decrease, but within the range that you would expect in these severely hypertensive individuals. So no indications that you deteriorate renal function post-renal denervation. That's probably one. And the second one was related to, what was your second question?
Yeah, how much contrast do you need for
contrast, yeah, right. So contrast is a big topic. We are running a study in CKD, particularly in CKD 3, 4, and 5 patients. And if you are trained, you can minimize the contrast to below 50 mL per procedure. You know, that depends a bit on how much visualization you need. If you want to go into the branches, you probably need more. But if you use a device that sticks and stays into the main renal arteries, such as ultrasound or even alcohol, you can probably do it with 10 mL of alcohol, with 10 mL of contrast, because you just need to ensure that you are in the renal arteries and then inject the alcohol. So you can significantly reduce it. In the trials, the amount was much higher, but that was more related to documentation purposes.
Yeah, when I was in Milano, I mean, we did a few renal denervations I did without contrast using CO2.
Yeah.
And using CO2 angiography.
Yeah.
And you can see pretty well enough to know I think was a dissection on any.
Absolutely. Yeah, absolutely.
Shun? Maybe one last question, then I have a last question.
Okay. Has effective renal denervation been evaluated in patient with HFrEF or dialysis subgroup? Any evaluation on those kind of?
So the problem with dialysis is that you get atrophic renal arteries, and then the procedure itself may be difficult. You have smaller arteries, but in principle, this is a very attractive and interesting potential patient population, because these patients die of sudden cardiac death because of increased sympathetic activity. So that's an interesting patient population, obviously. And there's one study ongoing here in Germany where we also participate in dialysis patients. And HFrEF is the one that we are now starting. From our side here, we got the funding 2 weeks ago, and now we will start a trial in patients with HFrEF, ejection fraction below 45%, but above 25. And if we could document the lowering in heart rate, we hopefully see an improvement in clinical outcomes too in these patients.
Felix, maybe one last question before we let you go. We're hoping in the United States, probably within the next year or so, we'll get renal denervation. You've been doing this for many years. Maybe some advice to us. How do we start up a renal denervation program? I mean, what are the tips to doing this properly, starting it up properly, making sure we get referrals? How do we do this?
So the big companies are now negotiating with FDA about the approval. The first pivotal trial is completed, as said. So I also expect that sometime in the next 1 or 2 years, you got approval for this technology in the US as well. And then you need a program. That would be probably my advice. A program where you collaborate with your hypertension experts, where you collaborate with your nephrologists, where you identify potential patients, and there will be many. So there's a huge amount of patients with uncontrolled hypertension, up to 50% in the US, right? So every second patient with hypertension is uncontrolled. And for certain patients, this may be an attractive option. In addition, and that's the second advice probably, in addition to lifestyle modification and antihypertensive medication. So this technology is likely not an option to replace drugs, to let them do whatever they want, but it could nicely fit into an algorithm where you take care of patients with uncontrolled hypertension. But I think cooperation and collaboration is probably the most important thing. You will see that the conservative colleagues are probably a bit afraid about the invasiveness of the procedure, and it also will take some time before that mind shift will happen. I mean, we are talking about antihypertensive medication for 70 years now, and now since 5-10 years, a new column of this antihypertensive treatment is now, rising. So a device that probably lowers blood pressure as part of the other two established treatment options, and that will take some time and also some negotiation and discussions, I guess, with your conservative colleagues to, you know, to let them know what that approach and what that procedure can do, but also what it cannot do. And this is not a cure for hypertension, right? It's not, that will not replace medication in every patient, and that is not a danger, a fear for our conservative colleagues, because we need the collaboration and we need the cooperation on that particular topic.
Great. Felix, that was fantastic. I knew we were going to get an amazing update on where we stand with renal denervation. Thank you so much. We all learned so much from you as usual. I miss seeing you, my friend.
Yeah, me too.
We'll see each other.
Thanks for having me.
No,
and thanks for listening.
Yeah, thanks for joining us. We learned so much.
And stay safe and healthy. Bye-bye all.
You too.
Bye.
Okay, bye-bye.
Thank you very much.
Bye.